Hello, we're back. Going on medicine. Took a brief hiatus just for a few days to get some things going. So you'll notice that that says July 2025, but we're actually shooting in September 1st. It is Labor Day. I'm currently at work. I'm at a slow spot, so I got to work out. And now I'm going to shoot this real quick before patients start coming in. As you can see, I'm repping Florida State. We just beat Alabama, so big day for me. Today we're going to talk about all things blood. I'm going to get some blood transfusion stuff talked about so that way everybody just says, give them the blood, give them the blood. But what does that actually mean? And what is in blood and what does it do for us? And what are its limitations? So here's what we're going to talk about. What is blood? Why can't I get anyone's blood? And then transfusion reactions. Okay. Basically, this is the safety portion of blood transfusion talk. Give me some little bit of history in here as well. As usual, I have no financial disclosures. If you want to give me some, please send them my way. I do not speak for the DoD or the JTS. This is all based on my opinion, which is the interpretation of data as I see it. I think my experience is pretty good, but other people certainly have much more and may have different opinions than me. Medicine is very much a gray area. Okay, get started. So, what is in blood? There are RBCs, WBCs, platelets, plasma, all right? And then what is the purpose of blood? So we're going to go through all of those things and then talk about each one individually. This will be kind of a rapid fire, probably review for a lot of you. Some of you, this may be a new thing, maybe just said the blood is the blood, dude. Doesn't matter what's in it. I would argue we're not going to be immunologists, but we should know exactly what's in it. Okay. Red blood cells. The purpose of red blood cells is to carry oxygen molecules bound to the protein hemoglobin to tissues throughout the body, essentially for energy production. And red blood cells also pick up carbon dioxide molecules in a minor fashion to the lungs for gas exchange out of the body. Most of the carbon dioxide is actually dissolved in the plasma, but some will go onto the RBCs. We got some pictures here that came out a little bit blurry than I wanted to, so apologize for that. But here's your RBCs and plasma. Um, Oxygen on a pressure gradient goes through the alveoli into the red blood cell, binds to your hemoglobin molecule, and is eventually dropped off in tissues. Uh, a lot of the carbon dioxide is actually dissolved in the plasma into bicarbonate, and then it dissociates and breathes off. All right, this is your hemoglobin molecule. It's a protein molecule with four iron binding sites on there, which will hold onto your oxygen that is within the red blood cell. Red blood cells are biconcave discs. They're sort of flatter in the middle. They have no nucleus. They are not technically alive. They cannot divide. They live about 3 months and make supposedly 500,000 circulations through the vascular system in a normal healthy person. Here's another picture. This is just at the cellular level in the tissues. Your CO2 is a byproduct of cellular metabolism coming out of the cell into the plasma and in the red blood cells as well. And it goes to the lungs where the gas exchange takes place. So primarily your red blood cells are transport vehicles for dissolved gases. Cool. White blood cells, lymphocytes. There's multiple types, okay, mainly responsible for fighting viral infections and then have a role in what's called adaptive immunity, which is essentially the way in which our body learns to respond to pathogens that are presented to us, basically the antibody producing section of our immune system. They fight bacterial and viral pathogens. They destroy cancer cells if they're functioning properly. And like I said, they perform these adaptive immunity functions, which is the development of antibodies. Cool. That's what they look like. These are the red ones are the red blood cells, and these big purple ones are the lymphocytes. This is only interesting to your like lab techs. Most people will not identify these for the most part. Neutrophils, uh, primarily responsible for fighting bacterial and fungal infections. This is one of the main things when you're clinically looking at someone's CBC. What is the number of neutrophils? What is the number of neutrophils? What is their absolute neutrophil count? Sometimes their neutrophil to lymphocyte ratio is an interesting thing to discuss, but neutrophils are one of your primary germ fighting, quote unquote, white blood cells. Okay, and that's what they look like. They look like a Rorschach mask or picture from Psych. All right, monocytes, multiple functions. They have antimicrobial properties, clearing cellular debris, and presenting antigens to other immune cells. So they bring things over and present them. And then eosinophils mostly parasitic function as well as play a role in allergic reactions. And the basophils involved in allergic responses by releasing histamine and other chemicals associated with that. Okay, that was a lot of like histology. We're done with histology for now. That's basic review of red blood cells, white blood cells. Here's platelets. I have no pictures of platelets because they're so small. Primarily function in the activation of clotting cascade and hemostasis. I think we've talked about this on previous videos when it comes to the trauma triad and trauma-induced coagulopathy and why whole blood is the way, and because whole blood contains platelets and partition products do not, and also platelets don't survive that long in storage, and so you're not going to have them in the operational environment or even on the ambulance, and so um, those are very important, mainly in hemostasis. Cool. And then here's our plasma. Uh, what is plasma? Plasma is like the stuff that's not the stuff. So the liquid stuff uh, that holds your other cells. Okay. Transports dissolved nutrients. It has hormones involved in them, dissolved gases, coagulation proteins, and it carries the thing. It is the water of your sweet tea, right? It's not the sugar, it's not the lemon, it's not the tea particles. It's the thing that all that is suspended in. Okay. And then if you were to donate blood and spin it down in a centrifuge, it would initially look like this when you first donate it, and then when you spin it down, it looks like this. So at the bottom are the erythrocytes, which are another name for red blood cells. That buffy coat right here, which is the white blood cells and the platelets. So if you were to do platelet-rich plasma, they would suck that out and inject that like into your knee or your shoulder or whatever. And then the top is the plasma, this part right here. So when you donate blood, if they partition it out, they suck up the plasma, they suck up the red blood cells, and the platelets. Cool. All right. Why can't I get other people's blood? This guy. This is the guy. Karl Landsteiner. Okay. Born in 1868 in Vienna, Austria. Scientist. In 1901, he was obsessed with blood. Big blood guy. Discovered the three original human blood types. They were originally labeled A, B, and O. Pull that up for you. Computer error. Bear with me. Bear with me. Okay. There's this guy, Karl Landsteiner. A, B, and C. Okay. They called him A, B, and C. C was later changed to O because of the German meaning of the word OHNE. Oni. I don't know if that's how you pronounce that, but Oni initially translates to in German without in English, signifying the absence of the A and B antigens that he saw on the surface of the other cells. Okay, so this guy is the guy who found the original blood types. Okay, then there's another guy in 1809, someone who worked with Karl Landsteiner, Adriano Sturley. He's a student of Landsteiner, and then Alfred von de Castello. We should give people their due, okay? Just because they're old and dead doesn't mean we shouldn't give them their due. We should remember who they were. So these people are important. Adriano Sturley, Alfred de Castello, and Karl Landsteiner. They described the fourth blood group that Landsteiner had originally missed, which is AB. Okay, apparently he didn't like when Landsteiner found all these, he like really had no idea what he actually had found. And I'm just going to read from my notes here. And he said, quote, I hope this will be of some use to mankind, end quote. Yeah, dude, like we were murdering each other by giving dog blood to each other. So yes, it has been good for mankind. So thank you, Karl Landsteiner and his students. These were also the guys who ended up developing the RH group, which we'll talk about later. Okay, here's blood types. This is across the earth. Okay, so like India, Peru, Congo, New Zealand, Morocco. As you can see, so most people are O or A. That's pretty like consistent throughout most of the world. There are some countries where there's decent size B, like India's got a decent size B, Vietnam has a decent size B, but on average, most places are mostly O and A. AB is the rarest in all the countries, and so mostly O and A, but some places have some decent B. And then this is in the United States. Um, this is our breakdown, so mostly O and A. And then if you look at like that AB negative, that's a super rare, 1% of people have that. Okay. All right. Types of factor. These are the four types of blood. Okay, so we'll get to the positive and negative, which you may be thinking, where are the positive and negative? We'll get about that. ABO and AB. These are the main types. And then RH factor. Okay. RH factor is the positive and negative component of blood. It's complicated, like with physics and biochemistry and but clinically, like in terms of what happens when you're Rh negative or positive, it's rather simple. We can break it down to a very simple thing for you to use on shift or at work. Okay. The main problem is in pregnant women. Okay, so if you are an Rh negative woman and you are exposed to Rh positive blood products or the blood of an Rh positive baby, in your subsequent pregnancies, you can have developed these anti-Rh antibodies. And if you now have a second baby who is Rh positive, so they are O positive, let's say, your antibodies can attack that baby and destroy its red blood cells, which is obviously a massive problem, fatal problem for a fetus. So this is called hemolytic disease of fetus and newborn, where this is a low risk phenomenon, but it's a high consequence phenomenon. So there's a medication called RhoGAM, which we can give to prevent the development of these antibodies. And so you should not like withhold Rh positive blood products to someone who's dying if they have not been pregnant or they're going to be pregnant or they are pregnant, but you should certainly document as such and get them programmed in an acceptable time frame. That is the main problem with these Rh positive and negative delineation in the blood is in pregnant women. It has very minimal effect on other people. So why can't they just get like anybody's blood? Okay, this is one of the big parts of the talk, that and the transfusion reaction. So we'll talk about this a lot. The main thing is antibodies. So blood types have antibodies in the plasma to surface antigens present on the patient's blood cells. Blood types are primarily defined by the antigens on their surface. So the blood has things that stick out on its red blood cell surface that will react to antibodies within the plasma. Okay. It's also named for the antibodies that their body produces against antigens present on the surface of red blood cells that the patient does not produce. This is kind of a mouthful, so I have a picture. Okay, here's the picture. We're going to go this one by one. Okay, so an antigen is a protein on the surface of the cell that elicits an immune response. Okay, that are these things, these red lollipops on the A blood cell. Okay, A blood group has anti-B antibodies, so it produces antibodies against the B antigens. Okay, and it expresses A antigens on its surface. Right, B produces B antigens on its surface and expresses anti-A antibodies. Okay, what about AB? AB has the A and B antigens, and since it has both of those antigens, it produces no antibodies. Okay. This makes AB the universal plasma donor because it lacks antibodies to any other types of blood. So when you pull off plasma, you're pulling off what's also in the plasma is these antibodies. So AB is the universal plasma donor because it will not react with anybody else's red blood cells inside of the patient. Okay. O has no antigens on its surface, and it has antibodies to both A and B, but as I said, produces no antigens. So O is your universal donor of red blood cells because any of the other blood groups have no antibodies that will see its surface structure because it has no antigens on its surface that are relevant. Okay. This also makes O the universal recipient of plasma as it has no antigens to present the donated plasma antibodies. Okay, kind of complicated. Review that again. Look at this picture. What about Rh plasma? Rh factor, excuse me. So, kind of what we talked about before. Avoid Rh negative childbearing age females from receiving Rh positive blood if possible. Here's the problem with that. Look at how much of the blood is Rh positive. Most of it, dude. So 6, 1, 7%, 9%, 16%. Only 16% of the blood is negative. So most of the blood, when you're finding it in trauma centers, universal emergency release blood, a vast, vast majority of that emergency release blood is O positive. Okay, that's fine. This is a fixable problem. We can deal with it. But a very small percentage is O negative. And so if you have some O negative blood, dude, you should hold on to that and give it to childbearing age Rh negative women if possible. You might not know they're Rh negative when you give it to them, but childbearing age women. If the person's 85 years old and they need blood, doesn't matter which. If you know, and then give RhoGAM if unable to avoid. You do not have to give RhoGAM immediately. You can give RhoGAM in a delayed fashion. Not platelets. Platelet sounds really complicated. I actually got like pretty confused reading the platelet guidelines, but I've kind of dumbed it down to what the people have told me. All right. Platelets are suspended in basically roughly 1 unit of donor plasma. That donor plasma contains the antibodies produced by that donor against other red blood cells, okay? As well as a small number of donor red blood cells because they can't like filter them out completely. All right. Um, this can cause like immunization against the red blood cell antigens, including the Rhd antigen. And when platelets are obtained from Rh positive donors or transfused to Rh negative recipients, there can be some problems. But like platelets are not at risk for intravascular hemolysis because when they're transfused out of the group. The plasma can cause hemolysis when ABO incompatible with recipient RBCs. But basically, platelets are given all the time in what is said to be a major mismatch, meaning you have A type and B type. Platelets are given across that all the time. Um, the transfusion risk is considered quite low, that oftentimes blood banks will ignore this problem. Okay. Like I said, I got quite confused reading about this. Most sources state that if you're unsure or you're worried about it, you can give O or A negative platelets, but oftentimes you can just utilize ABO mismatching and go from there. Okay, so platelets, you'll probably get universal platelets. All right, transfusion reaction. Okay, always be monitoring transfusion reactions. Okay, if the patient does anything, you should think about transfusion reaction. All right, these are all the main types. Okay, these are the big ones. Um, blood is medicine. Okay, and so if you're gonna point the loaded weapon of medicine at someone, you should be super freaking sure how that works, and you should be really sure how to do your immediate actions if there is a problem with that. Okay, if you're using any other piece of equipment or a tool, you need to know how to fix it if it gets broke. If you are starting to give people blood, which is a dangerous tool, then you should know how to fix it if they break because it's your fault. Okay? These are relatively simple to understand. We'll talk about which ones are like actually the most serious and which ones that are the most mortality, which ones really are more common. All right. Rule number one, I'm number one. Okay, so rule number one of blood transfusions. If they're having a transfusion reaction and you're not sure what it is, doesn't really matter. Stop the transfusion, call the blood bank, give no more product from that donor to that patient. Done. That's the rule. Okay? Stop the transfusion reaction, call the blood bank. I'll add in there, hold that blood so it can be retested. No more product from that donor to that patient. Okay. Allergic reaction. IgE mediated. Okay. Our eosinophils are coming into place there, and our basophils are coming into place there. Okay. 1 to 3% for platelet and plasma, 0.1 to 0.3% for RBCs. That is the risk. Okay. Symptoms are hive, itching, these mild allergic reactions. Give them some antihistamines. Stop the transfusions. Okay. Anaphylaxis. Okay. Much more serious than just a regular allergic reaction. 1 in 20 to 1 in 50,000 per unit transfused. Typically, they're from donor blood containing an allergen the recipient is allergic to, meaning I ate peanuts. I donated blood to the blood bank. That blood sat in there in the blood bank. They gave it to somebody who was allergic to peanuts, and then they had a reaction from it. Okay? That's the most common. That's super bad, bad luck for that person. That freaking sucks. But that's the most common. The other case can also happen where like the donor was allergic to something and then the recipient had eaten peanuts earlier in the day and the peanut allergen is like circulating in their blood and then like they get but that's less common and they get the reaction from the donor blood. Okay, multi-system findings meaning you have dermatologic findings like rash, you have pulmonary findings like bronchospasm, wheezing. You can get circulatory findings like hypotension. You can get angioedema, which is like facial swelling or persistent nausea and vomiting. So, like 2 systems, that is considered anaphylaxis. 2 systems plus exposure to an antigen is considered anaphylaxis. The treatment for anaphylaxis is epinephrine, 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 epinephrine. The treatment for anaphylaxis is not antihistamine, steroids, bronchodilators. The treatment for anaphylaxis is epinephrine. Other things are adjuncts. They are good to use, they're good to have, but the treatment is epi. It counteracts your histamine release and the other, it dilates the uh, medium-sized airways. It supports your blood pressure, vasoconstricts to avoid the shock that comes with anaphylactic shock and anaphylactic shock. It prevents that. And so the treatment is epinephrine. Do not delay treatment for epinephrine if you're like sort of not sure and you have a young, healthy patient. Otherwise, they will probably tolerate the epinephrine well. Anaphylaxis is not something you want to find yourself getting behind on. Okay, I would argue the treatment, the forced posture of anaphylaxis is aggressive. It's max aggressive at all times. Okay, do not delay. Okay. If you are giving blood, EpiPen needs to be around. Sorry, my light just turned off. There we go. Nope, turned off again. All right. Okay. The memes are for me while I make them. There was an allergen, so I triggered anaphylaxis. I'm a mast cell, so considered handled. The girl who's just burning it down for those of you who are just listening and not watching. Okay. Febrile non-hemolytic transfusion reaction. Super common one. Okay. This is like among the most common. All right. Uh, Occurs within 4 hours of a transfusion. In which there's no other explanation for why the patient has a fever of greater than 38 degrees Celsius or an accompanying temperature increase of 1 degree Celsius or higher. Okay, and you get chills or rigors. All right, about 1% of transfusions. It's mediated by donor leukocytes, um, along with accumulation of cytokines within the blood storage, interacting with the recipient antibodies, and they don't like each other, and so there's a mild reaction. Leuko-reduced blood products greatly reduce the risk. Most blood products from like a real blood bank at a hospital, or I don't whatever the products. Symptoms are very mild. Always follow rule number one: stop the blood product transfusion. Give them Tylenol, notify the blood bank, no more blood from that donor to that recipient. And then the big one is this is a minor reaction, but the big one is assessing for other reasons why they might have a fever. Some of these other reactions are associated with fever, like trolley or sepsis. And so these are big things to look for. Is that like, okay, it might just be a lame febrile non-hemolytic transfusion reaction, which is not anything to write home about, but you need to really make sure that they don't have something else. So this is kind of a diagnosis of exclusion. This is a big one. All right, so acute hemolytic transfusion reaction. 1 in 76,000. This is most often due to clinical error. This is a immune-mediated destruction of RBCs. Your host antibodies see foreign red blood cell antigens and destroy them and cause lysing of the red blood cells, usually within 24 hours, often very abrupt. Okay, this is the most severe is associated with a ABO mismatch. Okay, so hey, there's picture Carl Beinsteiner on the back of my paper. You give somebody A blood and they're B. Okay, someone's O and you give them. All right, so you cannot give the wrong blood type to the wrong people. Right? That's when you're not sure. Always give them O. But this is often clerical error. Okay. The classic finding, which you're not going to see in everybody, but if you give them a lot, you're going to see it. Fever, chills, back pain, or flank pain. Okay, you get hypotension there, blood pressure will tank, nausea, vomiting, their urine color will change. They go into renal failure. They can go into coagulopathy such as DIC, and just frankly go into multi-organ failure and die on you, especially with large volume. So stop the transfusion. Call the again rule number one, right? Stop the transfusion, call the blood bank. IV fluids to support the pressure and to support perfusion to the kidneys because your kidneys will sacrifice themselves. Your kidneys are the martyrs of the organ system family. Okay, they will sacrifice themselves for the preservation of the other organs. Or you could argue that they're the wimpiest of the organs. They are the lamest of the organs, although they are important. They will die first. Okay, so IV fluids to support perfusion to the kidneys. You will draw DIC labs, which is like the dimer, fibrinogen, coag, some of this other stuff, and then you will reverse the coagulopathy with the various products that they may need. Maybe they need plasma, maybe they need, whatever. And then plus or minus vasopressors. This is like norepinephrine, epinephrine, vasopressin to support their blood pressure if they remain in refractory shock despite your IV fluids. This is bad. This is like fulminant emergency. If you have an acute hemolytic transfusion reaction, it is a sentinel event. It is super life-threatening. This person goes to the ICU. They get CCAT out if you're in the deployed environment. They get helicopter to the big hospital somewhere if you're like stateside. Okay. That's not good. Okay, mortality 44% of transfusions exceeding 1,000 milliliters. Like the mortality for gunshot wounds in America is probably not 44%. So like you give somebody 3 units of donated blood, that's the wrong type. You're basically shooting them. Okay, and so that's not good. Giving blood has There are safety protocols when you give blood. You utilize like read back and close loop communication. You confirm the type of blood and the type of patient and whatever. And so you really need to follow those safety parameters before you give blood to confirm that you are giving the right blood to the right patient. Because as you know, this 3 units, sorry, of blood is going to approach that 1,000 cc's and basically almost half mortality. Okay. Overall, from what I like read in the data says the overall mortality was around like 5%. Okay, so not all of them go this high. Usually it's recognized early, but 5% mortality is a lot. You know, if COVID had a 5% mortality, you're talking millions, millions, and millions of people dead. So 5% is a lot. All right. Does anybody know who this person is? For those of you who are just listening and not watching, it is a person of a one-legged. It's a picture of a one-legged man in camo and a plate carrying a Boston Red Sox hat, holding an M4. All right, with a lot of tattoos. This is Nick Lavery. Okay, this is Nick Lavery. He is, I believe, he's still in. He's very close to being retired if he's not retired out. But so Nick Lavery is a Green Beret. In 2013, he suffered a green on blue attack in Afghanistan, where he took multiple PKM rounds to the right lower extremity. PKM, big machine gun, basically big Taliban machine gun, big machine gun used in like the post-Soviet world, the insurgent fighter world due to its robustness, long range, super big, fat round, and its ability to keep firing it basically in any environment. So took several PKM rounds to the right lower extremity. Uh, was incredibly ill. Obviously, after the attack, he had tourniquet placement on by himself and was medevaced out. When he went to the role one, and then in transit to the role three in Afghanistan, he received, I don't know the exact number, but an unknown number of blood transfusions with an ABO mismatch due to another casualty of the attack having a similar sounding name, is the answer that I have heard told in podcasts by him. I've obviously never spoken to Nick Lavery. I do not know him, but that is the best understanding that I come up with. Unknown number of whole blood transfusions with an ABO mismatch due to similar sounding name as another casualty who was transported with him. This resulted in renal failure, dialysis, multiple surgeries on the lower extremity. Ultimately, he did not die because he's a gigantic, resolute human. He did not die, but eventually he actually elected for the lower extremity to be amputated. And after that, he decided to not get a medical discharge, as many people would have probably done, and stated, I'm a freaking Green Beret. I'm going back on my team. And he ultimately is what is considered the first above knee amputee to return to an operational ODA and go redeploy back into a combat zone. They had to create like a special, basically, curriculum to test if he was fit to return to active duty, which he was. And he went back to Afghanistan, the place where he was hurt before, and continued to serve. And he's a motivational speaker now. I believe he's still in, but he's really rapidly approaching his 20. If he's not in, he's probably even beyond there. But quite an amazing story, and this is like one of your own guys who who is the epitome of like, all right, this ABO mismatch wasn't the only thing that almost killed him. The PKM rounds to the leg were worse, but the ABO mismatch could have pushed him over the edge, and just thankfully, was caught in time, and he did not die. Delayed hemolytic transfusion reaction is greater than 24 hours after transfusion. Um, it is response to basically a re-exposure of a foreign antigen. At some point in your life, you were exposed to a foreign RBC antigen, such as one from the Rh system, either due to pregnancy or a previous blood transfusion. You developed antibodies to that antigen, and should you receive blood products later, you may get a hemolytic delayed transfusion reaction, which is very mild. What you'll basically see is like your body eats up the donor cells, but it doesn't make you very sick. Instead of your hemoglobin rising after a blood product transfusion, which you would expect it to rise, you see a failure to rise, and you may see evidence of hemolysis on labs or peripheral smear, but no evidence of like hemodynamic compromise. I've seen this in a person like who presented like with jaundice, several days after blood product transfusion. It was probably a delayed hemolytic transfusion reaction, which we sort of figured out after looking at his peripheral smear, and he was very well appearing, and so really like nothing happened. But good to know. Why aren't my patients' hemoglobin getting better? Well, it's because of that. All right. This is a big one. Transfusion-related acute lung injury, TRALI. Highest mortality of all the transfusion reactions. So if you're kind of like zoning out about the Nick Lavery story or whatever, strap back in. This is the big one. TRALI is the big one. Okay. Responsible for 30% of all transfusion-related deaths in the US. Okay. Researchers for TRALI, you're super sick, dude. You are on a ventilator. You have sepsis. You've getting a lot of blood product, massive transfusion, liver disease, kidney disease, and then female donor. This is actually one of the questions on when you donate blood is are you a female donor and have you been pregnant before? That's on some of the blood product donation questions. Okay. Why is female donor such a problem? Tell you why. Higher TRALI incidence is reported in plasma from female donors because the data says that previously pregnant female donors have multiple HLA antibodies in their bloodstream often, and then their anti-HLA class 2 and HNA positive antibodies in their blood. Ooh, what does that mean? Okay, it just means that um, they got stuff in there. Okay, so what are HLA antibodies? HLA antibodies are human leukocyte antigens. They're found on most cells of the body. They're typically formed after exposure to foreign HLA molecules, such as through previous blood product transfusions, pregnancy, or organ transplant. So of those, blood transfusion, pregnancy, or organ transplants, pregnancy is the most common. Okay, so the people who have the most of those in their blood are formerly pregnant women, because that's just a lot of women get pregnant, right? And so less women have organ transplants or blood transfusions, and so compared to the number of people who get pregnant, and so that's the most common. Blood products, if those have high blood products with these people have high plasma contents of these antibodies and antigens, and so they get sick more. There's a two-hit hypothesis and a one-hit hypothesis about who gets TRALI. Okay, so the two-hit hypothesis basically you have primed patient neutrophils, okay, due to illness, shock, sepsis, organ damage, or surgery, and they are recruited to the pulmonary vasculature, to capillaries and blood vessels in the lungs, ready to fight off like anything bad that happens, okay? Uh, and then the second hit is they get a transfusion, they get a blood product transfusion, and your neutrophils go, yo, it is freaking on. We are ready to attack. And they attack, they activate their complement cascade, and it gets massive inflammation and capillary leakage, leading to pulmonary edema. Okay, um, fine, sure, I could buy that. Why does that seem good? Well, because the people who get it are like the sick people. Sick people get it, and so sick people get it, so their body must be primed already, and then they get sick after they get a vaccine. Fine. First two hypothesis seems fine. The other hypothesis is that, well, why do like just previously healthy people who get blood product infusion can get TRALI? Well, the one hit hypothesis comes into play. There is no first hit. It's just a threshold. Okay. The threshold is the person's healthy, no problems, but they get transfused with plasma that has high amounts of antibodies, and it activates their neutrophils and they get TRALI. Okay. So basically, that's to say we don't really know, but we know the risk factors. And so I guess you can also be primed to say, yo, we got a freaking super sick guy. He's a multi-trauma, polytrauma, broken legs. He got fell off a truck and they got shot 3 times. He got surgery. He's on a ventilator. We're going to give him a bunch of blood. Oh no, his stats are going down. He's getting a fever or whatever. Okay, so we're primed for TRALI. Higher risk with more plasma containing products. What does that mean? Like the greater ratio of the product you're giving that has plasma in it, the more likely they are to get TRALI. So, um, 1 in 5,000 RBCs, 1 in 2,000 plasma containing products, and then 1 in 500 of whole blood derived platelets. Uh, so the overall risk is probably less than like 1%, like a lot less than 1%, but the actual data on like how often people get TRALI is unclear because the symptoms are, they get hypoxia, uh, hypotension, uh, can't have fever, and they often have to go on a ventilator. And so it's like, okay, well, if it's like hypoxia and pulmonary edema and these things, well, like all these people are already sick already, so it's hard to tell. So it's probably unreported. Usually presents in 1 to 2 hours, but up to 6 hours post transfusion. It's usually quite abrupt. They get shortness of breath, tachycardia, hypoxia, can have fever and hypotension. And sort of the definition is they get bilateral chest X-ray pulmonary infiltrates, not thought to be due to CHF, congestive heart failure, pneumonia, or what's called ARDS. Okay, so non-cardiogenic pulmonary edema that is basically thought to be from the transfusion, which is essentially a guess. We are guessing if it's that. There's no like test for trolley. So you can see how it's underreported. If I'm a super sick person and I'm already on a ventilator and I'm already hypotensive and I'm already having oxygen issues, and then you get blood products and I get slightly worse, it's like, who knows if it's from the product or it's just their clinical course. So probably vastly underreported. Overall treatment is supportive, basically support their hemodynamics and their respirations and their oxygenation. Dude, I read this in one of the papers, which is like 70 to 90% ventilation, mechanical ventilation required. That seems super high to me, but hey, maybe that's accurate. That is from some of the papers that I read, and so um, low threshold maybe to provide aggressive supportive care if you find somebody who got blood products, got way worse right after, start to develop significant hypoxia, chest X-ray, infiltrates, and so just know that a decent chance you're gonna have to intubate that person. That's what it looks like. Super bad. This person also has the right side chest tube, so who knows? Maybe they were like a trauma, and then they got intubated after ARDS, and this is their ET tube in here. Goes down to the main stem bronchus right here. They have like a port of some kind, so this person sounds like they were already freaking sick before, which again is all points to like who's at risk for ARDS. Sorry, I'm looking at my TV up here, making sure the patients aren't coming in because I'm at work. All right, Taco, my favorite lead, favorite name. Transfusion-associated circulatory overload. This is volume overload leading to pulmonary edema. Um, it's like a heart failure type picture. Some people say that there can be an immune component as well, but they get pulmonary edema similar to an acute heart failure exacerbation. From the blood product transfusion volume, your major risk factors are CHF, if you can believe that, renal failure, hemorrhagic shock, and then multiple units transfused. It's not like the units, it's the volume. It's like the volume of transfused. Usually present within 6 hours of transfusion, kind of with signs of acute pulmonary edema and respiratory distress, so short breath, tachycardia. Hypertension, which helped delineate it from uh, trolley. And they also get JVD, which is just jugular venous. Essentially, get the big fat veins in their neck from back pressure, from elevated right-sided heart pressures. Um, Differentiation from trolley, bedside ultrasound can look at the heart and say, hey, is the squeeze like the heart's barely squeezing, or the heart is squeezy so good? Okay. Where's the heart just barely squeezing? If the heart's barely squeezing like that, okay, yo, that sucks. You might have taco versus trolley. They can also have JVD, fever absent, like I said, and then trolley can present with hypotension, whereas tacos usually the patient is hypertensive and will respond, fortunately to the treatments for heart failure. So this is like positive pressure ventilation. That's what that PPV stands for. That's BiPAP. That's the Bane mask. Okay, I feel so good breathing through the BiPAP because I'm dying from my bad heart and the blood products you were trying to save me. So like that's the risk of being like crazy over aggressive with the blood products. If you get that systolic over 100 with blood product resuscitation and they're in hypovolemic shock, you're done, dude. You don't have to ever resuscitate them with 30 units of blood products until their blood pressure is 170. Stop. All right. It will respond to nitrites and diuresis. Okay, sepsis is our last one, and then we're done. Uh, Sepsis is secondary to bacterial contamination of transfused product. Platelets are the most commonly implicated product because platelets are stored at room temperature. So all the bags have germs inside of them. Okay, they all do because you can't like totally clean the skin, and then sometimes people touch the bag. Okay, and the bag gets germs in them. Fine. Platelets are often stored at room temperature, and so the bacteria can grow inside the platelet bag, basically. The transfusion, this is associated with like 1 in 50,000 platelet transfusions, but only 1 in every 5 million transfusions with red blood cells because the red blood cells are stored cold, right? Which the germs cannot grow, basically. Uh, Patients will rapidly develop high fever, chills, rigors, tachycardia, hypotension. They will look sepsis. They will look sick. They will get a fever. They are like, oh my God, you're like have a bacterial infection inside you. They probably do. So you should be given broad spectrum antibiotics. And so you can see how that the sepsis and the trolley and the uh, major ABO acute hemolytic transfusion reactions can all look similar, okay? Because they basically take somebody who gets super freaking sick, gets a fever potentially, gets low blood pressure potentially, and so you're all like, well, what the hell is wrong with this person? I don't know, dude. You should probably treat them for all things, and you should cover them all with broad spectrum antibiotics and supportive care until you can buy some time till the picture becomes more clear with DIC labs and some of these other things. Sepsis can devolve into DIC, and so that's not really a blood product specific issue. Anybody with sepsis can progress into what is called disseminated intravascular coagulation, so DIC. And so anybody can happen to that. That's not specific to like this type of sepsis. Okay, who gets the sepsis? All right, this is I won't say like landmark paper alert, but this is a big paper. Um, Journal of Surgical Research 2025. This is pretty new. So it says September. Look at September 1. I saw it before then. March, published in March. Okay. So I don't know some of these people, but I know some of them. Mike April, emergency medicine research leader extraordinaire, currently the program director of Brook Army Medical Center, my residency alma mater, someone near and dear to my heart. Andrew Fisher, Beast, he is basically on every single paper ever written in the United States Army in terms of combat casualty care, critical care, blood products, all that kind of stuff. That you want to feel real good about yourself, you should read Andrew Fisher's bio. Go ahead and Google that. Julie Rizzo, a beast in her own right, trauma, burn, um, a force of nature, and then Steve Shower, uh, critical care, EM, research. We've covered many shower papers on this channel. Also a BAMC guy at some point in his career, hopefully coming back um, later, and a big lover of the house music. So they wrote this paper that says who gets the sepsis, okay? They basically sought to determine which blood products were most associated with severe sepsis. They looked at 83,000 patients, 1,400 met severe sepsis criteria, um, and basically all these people, four of these people, 4% increased odds of sepsis with each unit of whole blood transfused. Okay, every unit of whole blood you get, 4% increased odds. Okay, severe sepsis patients were generally older, male, higher percentage of severe thorax injuries, and received more packed red blood cells, whole blood, platelets, and cryoprecipitate and plasma. The more bad stuff can happen. Basically, this is not, necessarily groundbreaking, but should confirm what we know, right? The more of something you give somebody that wasn't made by their body, the more dangerous it might be. But if they need it, they need it. Give broad spectrum antibiotics, fluids, pressure support, coagulation reversal. Okay, we are almost at the end. What about getting HIV? Okay, who cares, dude? You're not going to get HIV. All right. So hepatitis about 1 in a million, Hep C 1 in 2 million, human T cell leukocyte virus. I think that's what that stands for. HTLV. I don't even. That's like a different type of HIV, sort of a different type of immune deficiency. Something happens to you. 1 in 2.7 million. HIV 1 in 1.6 million. That's not gonna like. Don't worry about that. There are way more common things that happen. Basically, what could happen technically is that the person contracts one of the donor contracts one of these diseases, and then essentially like immediately goes and donates blood is how that works. And then you get this weird stage where they're not exactly testing positive for the disease, but they technically have the disease in their blood in a very low level. And then when you get that blood, then you get sick. It's like mostly theoretical. There's very, 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 very few transfusion associated like seropositive cases nowadays. That's not always used to be the case. In the 60s, 70s, and 80s, people were getting these diseases a lot from blood products, but not anymore. Thank God. Germs, and more germs. So for some of you who work in the expeditionary environment or work in uh, expeditionary medicine. So you are a freaking guide, or you climb Kilimanjaro, or you go to Everest, or you work in the safari in Africa, and maybe you have a really robust blood supply. I don't know. That would be pretty sick. But if you go to far, far away lands, or you do mission work or something, there's different germs there that maybe we don't have to think about in the United States. So sometimes these places are gross, all right? And that's just say that like as a joke. They're beautiful, but like I've been to places that have malaria and Chagas disease and some of these other things. They lose a lot of their blood products to these diseases because they test for them, right? They, they test for them and they realize that they can't use it. So if you go to Africa and you're going to do a whole blood product transfusion on somebody, you better freaking be sure that that donor does not have malaria. Okay, you better be sure that you go to some of these places that you test for Chagas disease and you test for Hep A, all right, and you test for West Nile, some of these endemic diseases that are just like super common in the general population. If you're doing whole blood product stuff, you need to make sure that these people do not have these diseases that will ruin your blood product supply. Okay, a lot of them have point of care testing kits, especially like malaria. You can definitely do that point of care testing. We made it. We have made it to the end. Speaking of these, I think our next one's going to be on malaria. I said for the public health peeps that we would do that. Blood is complicated, right? If you're giving blood, you should definitely know what it's made out of, and you should definitely know what it does. If you're giving any medication, and blood is definitely a medicine, you need to know its complications inside and out so you know how to fix somebody when you break them. It is a myth that we can't hurt you with our stuff. It's a myth that the doctor only helps me. The doctor can totally hurt you, and you need to avoid hurting people by knowing how to use your tools. All right. As always, okay, so I'm not fancy, so I don't know how to like make a link in here, but Stolen Valor Medicine is the channel. Please send it far and wide to any single person that you've ever met who would want to use this. Um, I'm not making any money on stolen valor medicine, as you can imagine, but just get the word out, right? I just do it for fun. I do it because I think people need this training. I do it because I think people want this learning. And so, yeah, send it to your friends, send it to your mom, send it to your dad who's a paramedic or whatever. Soul and Valor Medicine is the channel. It's the only one. And then, as always, at the bottom of the page, it says just what I believe, which is trust your gut, do your best, be a good teammate, and always stay in the fight. And that fight looks different for everybody, but we need you in it. So thanks, everybody, and we'll see you next time. The next video will be on malaria. The one after that will probably be on tuberculosis. I just read a fascinating book, and yeah, we'll see you. Thanks. Oh, last thing, I know my sources on this PowerPoint, but I have them right here. All right, so they are sourced. I'm not claiming plagiarism. Sourced. I didn't just make it all up. Cool. Now we're gone. Thanks, guys.